Welcome, everybody, to our forum here. We're going to talk about a number of different areas from San Antonio this year and interesting topics. As you know, web conference is sponsored by Total Health Conferencing, and we have support from Pfizer, Agendia, Biotheranostics, and Daiichi Sankyo. So we're very grateful for that support so that we can talk to you this evening if you happen to be on the East Coast, and this afternoon if you're on the West Coast like myself. We have a great group of people. I'm Hope Rugo, Professor of Medicine and Director of Breast Oncology and Clinical Trials Education at the University of California, San Francisco's Comprehensive Cancer Center. And I'm joined today by 5 excellent colleagues, and I'm going to have each one introduce themselves. Charles, do you want to start?
I'm Chuck Vogel, not Vogel, New York. I'm from University of Miami.
It's Vogel, Florida.
Vogel, Florida, yeah. Breast medical oncologist.
And Sunil?
I'm Sunil Badve, Professor of Pathology at Indiana University. I'm interested in breast pathology.
Great. And Muaiad?
Yeah, my name is Muaiad Kittaneh. I was in clinical practice until a few months ago. I was associate professor at Loyola University, and currently I'm a medical director at ICON Clinical Research.
Wow, that's a big change. Well, that'll be interesting. It'll give us a new perspective as well. Valerie.
My name is Valerie Mitchell, and I am a HER2 positive breast cancer patient, survivor, hormone receptor negative. I was diagnosed in 2016. Went through Herceptin, Perjeta, Taxotere, carboplatin, bilateral mastectomy, followed with radiation, had lymph node involvement, and then did a year of neratinib.
Great. Thank you for joining us, Valerie. Your perspective will be incredibly helpful for us. And Peggy.
Thank you. I'm very honored to be on this panel today. Thank you for the invitation. My name is Peggy Johnson. I live in Wichita, Kansas. I'm executive director of Wichita Medical Research and Education, but I'm a 30-year breast cancer advocate with Susan G. Komen, and I am an 8-year cancer triple negative breast cancer survivor.
So both of you, congratulations on how well you've done, and thank you so much for participating today. Now to the audience, you can send in questions, and I think you know how to do that. Do send in questions. We have a great panel, so having this discussion will be very helpful. We're going to actually cover a fairly broad range of topics, and any question is okay. We're going to start in talking about HER2 positive disease, and then we're going to talk a little bit about some of what we have learned and understand about hormone receptor positive disease, and we're going to also talk about some of the really interesting gene expression data that we saw from the different studies and the different tests that are available at San Antonio. But again, we have lots of other areas that we can talk about. If we have time, I'd like to be able to also briefly touch on some of the really interesting disparity data that was presented at San Antonio in a special session on Tuesday. Actually, there were 2 special sessions. One was on the disparities and one was on COVID-19. And actually, I really encourage you to go back to the audience and listen to these if you have time, because they're really interesting. So let's start and talk a little bit about HER2 positive disease. And actually, I'm going to start in a little different way with Valerie first, just to ask you, Valerie, at San Antonio this year, and overall, what are the most exciting areas to you about the treatment of HER2 positive breast cancer?
I think I get really excited about all the different research coming out with the new treatments, especially in the metastatic community. Because those are the girls, when we're in support groups, those are the girls we're losing. And so wanting to know more about what's being done for them. Also, the question that always comes up in the survivor community, and I don't know that it's being studied, at least in this format, but what starts this to begin with? What makes a person susceptible for HER2 positive breast cancer? And is there anything we can do to prevent it? Also curious if anything's coming up genome-wise. Like, I know that I had genetic testing. In my case, they said, we don't know. We didn't find anything in your genes that said that you were susceptible for this. Didn't know if there's anything unfolding in that or not. But those are my questions.
Well, those are great questions, actually. And I think, we'll talk a little bit more about some of the novel therapies. But Sunil, I'm just interested from your standpoint in the sort of pathogenesis or different pathways of development of HER2 positive disease, and this question about genomic risk, which I think really confuses people and makes them anxious.
Yeah, I mean, there's a lot that we don't know. So let's start with that basic understanding that we don't know why people develop breast cancer, by and large. There are small groups of people in which we have a slightly better understanding. And these are the patients who have the classic BRCA mutations. And then now we have a larger cohorts. As we studied them, we found that there are a number of other genes that are related to DNA repair pathway that are associated with increased risks. But still, a vast majority of times, we don't know why people develop breast cancers. So we believe it's multifactorial in origin. It may have to do with anything and everything that you did or did not do. So it's not anything that patients like to hear because breast cancer is not one disease. It's multitudes of diseases that occur at one common site, which is the breast. And as has been shown by gene expression studies, DNA mutation studies, each cancer can be quite different, and they may have a bunch of mutations that are associated with it. And we are trying to use all of these informations to direct precision therapies, as they are called these days. So that's the way one needs to think about it, that this is a bunch of things, different etiologies, different mutations, different changes, but all occurring in the same anatomic location. And that is what combines them into what we call breast cancer.
So that's great and really helpful. Let's turn and talk about some of the new treatments. Muaiad, I'm going to get it right, we heard some interesting data. There was a HER2 spotlight discussions, the name for the San Antonio poster discussions. And we saw some interesting data. I thought that the update on trastuzumab deruxtecan was quite interesting. What did you think of that data? Could you tell us a little bit about it?
Yeah, I'm going to defer actually this answer to Dr. Vogel. This particular abstract, I did not look at it. I have to be honest with you.
No worries. It actually is really fascinating because it's a longer follow-up from this Destiny Breast01 phase 2 trial. So Chuck, I know that you've been following along this data quite closely. What struck you about the longer term follow-up that was presented? You're on mute. You're on mute. Still on mute. There you go. Excellent.
Okay. Well, I was struck by the 19.4 month result. That's about, was that disease-free survival or?
That's the progression, because of metastatic disease, the progression-free survival now is 19 months compared to a little over 16 months when they first presented the data with longer follow-up now.
Yeah. Well, I think that's pretty striking. As metastatic disease results go for a single agent. It's a single agent, but it's basically a conjugated compound. So I was struck with that as a major factor. The downside to the compound, of course, is the interstitial pneumonia. And although it's not a common complication, it can be a severe complication, can be a fatal complication. But I think that this particular compound is going to challenge our entire sequence.
Oh, your audio just went away, Chuck. Sorry. I'm not sure where. We can only see half of you too. I don't know if you can move to the middle of your camera because we can only see half of your face, which we want to see all of your nice face. But So yeah, you're coming and going still. I'm just going to pop in with I agree that progression-free survival in patients who'd received a number of lines of HER2 targeted therapy, although it wasn't prescribed exactly what they had to receive, they extensively, was quite impressive. 19 months is really quite dramatic. And the overall survival was a little over 2 years, the median overall survival, which is also, I think, very impressive in patients in this situation. And of course, our interest is moving the drug earlier in the line of treatment, but the ILD is still an issue, the interstitial lung disease, with patients who are could get inflammation of the lung. And there was one more grade 1, one more grade 2, and one more grade 5 or fatal ILD seen. Most of the events occur in the first year. They had a nice time course with one event that was a lower grade occurring after a year. And I think that we believe is that we can diagnose this earlier if everybody is aware and educated, understand the risk factors, and really reduce this risk. I have a patient who was on Destiny Breast 01. She stayed on TDM1, trastuzumab emtansine, for a year, but then she's now been on trastuzumab deruxtecan for 2 years. She went off the study and went on to regular drugs so she could do her scans less frequently, but she's just done beautifully and had disease that progressed after a year on the Cleopatra-like regimen. So this is clearly a really important new treatment for us. I'm interested in what, Muaiad, did you use this in practice before you left, and your general thoughts on this regimen?
No, the only thing with the deruxtecan is really, like you mentioned earlier, is the pulmonary toxicity, but I have not seen it. I have used it maybe only in one patient before I left. I don't have a lot of experience in using it to speak about it. So just,
So I think that's, it is interesting because I think that, we saw a HER3 antibody drug conjugate. Chuck was talking about how this is a unique agent, and we've been so excited about the way antibody drug conjugates work, where you have an antibody that's targeted. HER2 is easy because we know to target HER2. But now there's an antibody, well, we might disagree, but we know we can target HER2. And HER3 is a new area. And so there was another poster discussion. Ian Kropp presented a poster using this HER3 antibody drug conjugate, also from Daiichi. And this ADC is a antibody directed to HER3, whereas trastuzumab deruxtecan is a biosimilar to trastuzumab. But the linker, they can get a lot of drug onto the antibody compared to TDM1. There was only about 3 or 4 toxins per antibody. Now they can get 7 or 8. And the toxin for these 2 ADCs is this deruxtecan. It's a exatecan derivative, and we believe that that's probably the drug that causes the pneumonitis, because certainly not the antibodies, as far as we can tell. There's a low rate of pneumonitis reported with TDM1. It's just, none of us have seen it, but it has been reported. We see, for example, nodular regenerative hepatitis with TDM1, but we still give the drug. So I think it's an interesting question about what to do with the ILD with such an effective drug. Thankfully, it's extremely uncommon. So Peggy, and Valerie, I'd be interested in your thoughts on what your take is on hearing about that ILD and how people can be monitored and treated for ILD. Peggy, do you want to briefly comment?
You're above my pay grade right now. So, my concern always with new drugs is the community that it was tested in, to make sure that we've got a good stretch of the total community and what the availability is going to be. Is it only going to be available in major cancer centers? Is it going to be available in smaller communities? I think that's one of the things that we worry the most about new therapies. We love new therapies. That's why we're all here, is to find new therapies and new cures. But we also want to make sure that it's being used as widely as possible in all populations, if appropriate. And if appropriate is the question.
Yeah, and I think that brings up a really important point, and I don't think I'm above your pay grade here. I think you answered the question perfectly, absolutely perfectly. And you don't really need to know what interstitial lung disease is because you know that it's some inflammation that's not good. That's pretty much what we know too. But
I don't mind chiming in also on that.
no, I'll have you chime in. I think the one thing I wanted to point out is that we don't know which, like if there are any differences between racial or ethnic groups in terms of the risk of ILD. Go ahead, Valerie.
Yeah, I think when I looked it up, I saw that there's about I believe a fifth of the population maybe develops this. And I think as a patient, I would want to know what are the ratio, what are the signs that I look for, and I'd also want to be sure that it's a patient who had a really good connection with their physician so that they can really monitor. So many times for patients, we don't want to be a bother. We're always like, oh, doctors have so many things. And so we really have to have that comfort level of knowing how do we monitor ourselves and how do we accurately report if we're getting some sort of symptom. Is it just a cough? Is it just a tickle? Is it something more? Do I bother my doctor with this information? I think
the answer is yes.
Yeah. That's such an important thing to mention, Valerie, because one of the things that I think we all teach about a lot is that, you know, every single time I see that patient I have who's been on now for 2 years, every single time I see her, I say, you know, I know you're feeling well and it's been a long time, but if you get a cough or any symptom, you need to let us know. And it's also important to let your whole practice know too. And reinforcing this for patients is so important because people forget, actually, there's so much going on, so much with their disease that it's not important. It's not a fifth, just to keep in mind, it's less than 10% incidence. And the real part that we, of course, are worried about is the grade 5, where people die of ILD. And the idea is that if you could catch like a little, what we call ground glass opacities or some haziness on the scan, and you could stop the drug and start steroids if patients have any symptoms, then we might be able to prevent all of this. And I think that's where the education is so incredibly important. Chuck, I wanted to ask you, what do you think about re-challenging with trastuzumab deruxtecan? Is there a situation where a patient had, say, grade 1 ILD? Would you ever consider re-challenging at a lower dose?
I might consider it at a later point in time. I don't know that I would go back to it immediately. But if they had only grade 1 toxicity, yes. If they had more than grade 1 toxicity, I would not re-challenge.
Your audio is out again.
Anybody hear me or?
Well, you're frozen and your audio is coming in and out. I'm so sorry. It may be that if you, you're using your phone for the audio. Maybe use your phone for the audio because your video is frozen again.
I'm unmuted. You're frozen.
Yeah, it's because your signal isn't good for your video. Maybe, I don't know.
I can probably try to take that question and
okay, great. Thank you.
No, yes, not a problem. So generally speaking, as you know, and on clinical trials, when the toxicity is less than grade 2 for most of the drugs that we use, and if there are no better alternatives, most of the time you can probably re-challenge the patients with a grade 1 toxicity. And just to your, you know, to the patient and the advocate on the call, is a grade 1. It means something that does not interfere with your activities of daily living. You can still, you know, you have some shortness of breath as a side effect from the drug, and you probably have some changes on the CAT scan that are evident, but it does not necessarily interfere with your activities of daily living. So anything less is considered less than grade 2. That's a grade 1. So in general, as a concept, a patient with a grade 1 toxicity can be potentially re-challenged with a close observation. And I don't know if you, Dr. Rugo, if you agree with that or not.
Well, I would say, you know, grade 1 with close observation, I think is very reasonable. Anything over grade 1, which is when you start having symptoms, I wouldn't ever re-challenge. And it's really, the labeling says stop permanently. I think that, that just the concern is understanding this more. We have phase 3 trials now that have been completed comparing, for example, the TDM1 or Kadcyla to trastuzumab deruxtecan or HER2. And I think that that will help us a lot understand the risks in terms of ILD and how to manage this more. But right now, because the risk seems to be low, and the grade 5 was 2.7% in a high risk, heavily pretreated population, I think the benefits of the drug in heavily pretreated patients outweigh the risks substantially because you can stay on for so long. It works so well. We'd love to see it in earlier, and we're going to see more studies on this. And, understanding how it works in patients with stable brain metastases is really important. The trial did allow patients on who had stable brain metastases, and they did appear to do quite well with that drug, although we don't have the same kind of information that we have with the tucatinib treatment. So I wanted to just talk a little bit about HER2 Climb. There was some data on hormone receptor status. Both studies presented quality of life data that was very good, really nice quality of life data, which was great, and including with HER2 Climb. So Chuck, I don't know if you're back now, if you might want to comment on the HER2 Climb data briefly.
Well, Her2 Climb is a very exciting combination. Basically, it's tucatinib plus Xeloda plus Herceptin. Can you hear me now?
We could, but now you're fuzzy again.
I'm fuzzy again?
You're okay right now.
Well, I redialed into the Zoom instead of the phone
Good.
and the Wi-Fi, so I don't know.
Now you're doing okay.
Okay. Her2 Climb, I think, is very exciting, especially because it was unique in accepting patients who had active brain metastases. So not only did you get information about systemic response, which was impressive, but you also found that patients could be treated with this compound, with this combination, and get excellent responses in active brain metastases before radiation therapy. And in the group of patients with and without tucatinib with regards to brain metastases, the results were quite striking in favor of tucatinib. So now we have a bit of a dilemma. We have the tucatinib combination. We have the deruxtecan data with that 19.4 month really exciting end result. We don't yet have the same type of information in the brain with deruxtecan, and we have the problem of interstitial lung disease. So there are a number of exciting trials that are ongoing. I think the deruxtecan compound is going up against Keytruda. If I had my guess, it's going to beat, not Keytruda, I'm sorry, Kadcyla.
Yeah.
And if I had my gut feeling, I would say it probably, in terms of efficacy, will exceed the results with Kadcyla. On the other hand, and we can put this back to our patient advocate, here you have a drug, here you have two different drugs that are conjugates. One of them with really excellent efficacy, but with a potential for serious toxicity, and the other one with very little toxicity, excellent quality of life, and quite reasonable efficacy. And you're faced with that decision. Which of those, when that study reads out in a year or 2 years, and let's say that the deruxtecan shows better results than Kadcyla, how much is that 10% interstitial lung disease going to weigh in on your decision with your physician?
Well, I think that that's a really good question for Valerie and then Peggy to discuss. I think that, some of the questions that have come in are related to how we sequence these agents, seeing this remarkable data, and the update at San Antonio was no difference. The efficacy was similar between hormone receptor positive and negative disease, little trend towards better efficacy in hormone receptor negative, but that's probably because more HER2 enriched. But the toxicity of tucatinib, trastuzumab, and capecitabine was more diarrhea and more liver enzyme elevations, but both of them were modest, and the discontinuation rate for side effects was quite low. Same with trastuzumab deruxtecan. It's really ILD, the lung inflammation, that would make you stop. So I guess that's the question, really. We can talk a little bit about how we would sequence them based on medical choices, but for Valerie, what are your thinking? What's your thinking about that?
So, I think as a patient, my attitude has always been, bring it on. What can I do? I don't want to revisit this again in the future if I can. So anything I can do to prevent would be great, or extend. So that tends to be my go-to, is even if it's a little bit harder, if it feels like it's going to give me more benefit, give me more time, I will go with it. But I am also thinking too about asthma. Lung, if I've had lung issues in the past, and I have had mild asthma from time to time, and allergies and things like that, so I would be mindful of that and thinking, do I have some predisposition to having some lung disease? How effectively can we monitor it? What does the monitoring look like? Those would be my questions.
Yeah, I think those are great questions. And Peggy, what's your thoughts on that?
I believe that the patient should always have all of the information, that the doctor doesn't try to weigh it one way or the other way. I think it's going to make a difference whether it's a mother with 2 babies and she's trying to juggle everything. She needs to know that she's maybe not going to feel as good, or her quality of life is going to be better. And I also think when you talk to an older patient, those are going to be things they're going to think about too. And so I think the thing that I always want to encourage is that you have an honest conversation on both sides. Don't you? But I think we always have to make sure that the patients have all of the information so that they can make the decision. I think an older patient's probably going to say, I want to be comfortable. And so I'm saying we need to empower the patients.
And I agree with that. Having consented a number of patients just recently for a phase 1b trial where we're looking at this trastuzumab deruxtecan with the checkpoint inhibitor pembrolizumab, it's been an interesting experience to try and help patients understand what the risk is. And basically what I think has worked is to help people understand that we have to partner together on this, and that they have to let me know. The patient came in today and had all sorts of side effects she call about, these are the things say, really, this time you really have to call. You're not bugging us at all. It's really important. And even if it's a pain for you to get on my chart or call in, so that's important. It's interesting because when you balance the patient experience, in some ways getting an IV drug every 3 weeks, if you could control nausea and diarrhea and not get ILD, it's going to be easier than taking a bunch of pills all the time and worrying about what you eat and diarrhea. So, it's a balance. For some people, not coming in is really important, and you can get trastuzumab or Herceptin now subcutaneously. So you could come in for a short time, much less frequently, right?
Yeah, that takes us back really to where the whole question started about the Her2 Climb data that came from the San Antonio breast cancer meeting, looking at the healthcare quality of life data. Because as you think about it, in patients being incorporated in the production of data in the clinical trials by reporting their quality of life on these studies, it helps other patients in the future to decide on this. And the Her2 Climb, as you know, in this study, it was reported that those patients that received tucatinib in combination with the trastuzumab and capecitabine in comparison to the placebo component, they had really a longer time with improvement in maintaining their quality of life, which means they received longer of the treatment, and as a result, they are able to achieve the outcomes of overall survival data that we talked about. So in other words, the longer they are on treatment with a better quality of life, the better the outcome. Having said that, it is not comparing it to deruxtecan, trastuzumab deruxtecan, to say like, one is better than the other, especially when you're not talking about health-related quality of life data.
So one of the things we saw, which Chuck reviewed really nicely, was that we've seen this dramatic improvement in PFS and overall survival, which is remarkable at this first evaluation in Her2 Climb. And we saw it in patients who had untreated active, albeit asymptomatic brain mets, as well as the others. So I think that's quite interesting. And one of the questions that came up is, it's not, this triplet is not approved until second line by insurers. But is that something that we're going to have to stick with, or what do you think about that now that you're going into the sort of other world here from practice? And maybe you could comment on that. I recently saw a woman who unexpectedly had a recurrence with brain and other metastases, but multiple brain mets. And she got radiation and she started first line on Her2 Climb regimen. And I saw her as a second opinion about 4 months into the treatment. I mean, her disease is almost gone. And it's really, really remarkable. And, she had a little trouble with diarrhea and all issues. So they dose reduced the tucatinib, and it's just a remarkable response. So I guess the question is, for all of these drugs, will we be moving them earlier, and how we deal with that from a funding perspective?
I mean, that's a challenging question all the time, funding and, insurance coverage, and taking, cost of care into account in making treatment decisions. A lot of times I would say, unfortunately, these decisions are made by insurance carriers rather than by, patients or, healthcare providers. And as you know, a lot of times we have to get on the phone, make these calls, talk to them, providing them with the data. But a lot of them, they go by, the guidelines. In other words, if the NCCN guidelines, as you know, is listing the agent or the combination in the sequence, and if there are any other biomarkers that are needed to approve the study, to approve the drug, then they would approve it. And I've seen a great variation in terms of insurance carriers when it comes to, giving, especially newer treatments to patients.
And
So
Chuck,
can I jump?
yes, Peggy, go ahead.
Can I jump in here? So this is a great public policy lead in here, because what you're all talking about is who's making those decisions. And we have for several years tried to get legislations called fail first, that you have to fail on a drug before you're able to take the next generation or the newest generation of the drug. And this has been something that Komen, American Cancer Society, LLM, we've all been working for in Congress and in state legislatures, that number one, they have a limit on how long you have to fail. And we'd all like to see it 2 weeks, 30 days, not 6 months, not a year, but it depends upon the drug. And it depends upon the insurer. And the other thing that we want is we want them to come back and give us an answer within 72 hours. If they're going to say, no, you've got to be on it for 3 months, tell us in 72 hours. So start listening.
If it's
and start looking. Legislation will feel first.
In California, where we deal with a lot of insurance issues, and now everybody is, but we had more earlier. We don't get you had to be on it for 3 months. We get no, and it's not on the NCCN guidelines. And I think, that's one of the issues we have is, trying to treat patients based on what we know might work better versus where these guidelines are coming. Thankfully, NCCN doesn't opine so much on the sequencing in metastatic disease, but it can be an issue in early stage breast cancer. Sunil, just a question to you about, oral tyrosine kinase inhibitors and antibodies, and sort of just some maybe overall comment about that. I think, this was really a remarkable result that we saw with Her2 Climb. And I think I personally have hypothesized it's due to the addition of the antibody. And getting the ADCC in there too, even with resistance. But what do you think about, I mean, that's our understanding of these drugs.
So, I mean, there's a lot we know and a lot we don't know, like usual. But we have really not, in spite of playing with the HER2 molecule for almost 10 years, we have very few real knowledge about or data regarding what are the mechanisms of resistance. And particularly with some of these new drugs, you don't need to be even traditionally HER2 positive to get response. There's all this new category of HER2 low, which is what we are talking about with the Destiny-01 and the Destiny-04 trials. And for us in pathology, we really do not have a great handle of what the responses will be and what we should be calling HER2 low. We are using assays that were designed to pick up HER2 3+ positivity and exclude everything else. But these assays may not be the ideal assays to pick up patients who are expressing lower levels of HER2 that might respond to these newer agents. So that's one thing. The second question, of course, is penetration of the agents is important, and the small molecular inhibitors are more likely to penetrate better. So the HER2 Climb, for example, uses a small molecular inhibitor, rituximab, which has much greater penetration of the blood-brain barrier as opposed to the bulky antibodies that we have. So there may be some of that. And then lastly, of course, toxicity profiles are different for different agents. And so those are the ones that you as clinicians and patients need to be worried about to figure out what are the acceptable toxicities in any given situation. So those are kind of complex questions that everyone needs to think about. But what's more exciting is the response rates in patients who would be traditionally called HER2 negative. And anti-HER2 therapies working in those subgroups is really a major change, because now we have we really don't know what HER2 low category could be and what the total amount of HER2 positive disease is going to be, because traditionally we have been thinking of HER2 positive disease as around 15, maybe up to 20% of breast cancer patients. With HER2 low patients, we may have another 50% of breast cancer patients who might be eligible for these new kinds of therapies. So other question that we had just asked in the multidisciplinary tumor board as we were discussing these issues is that if you have a HER2 low patient or a classically HER2 negative patient, would you treat him treat her as a triple negative patient with breast cancer metastasis and use one of the newer triple negative agents, or would you use one of these HER2 type agents? And that was a really interesting discussion. I wonder what you guys think on this, because we have, I would really like to hear your opinion.
Well, so yeah, that opinion would be great, but I just want to clarify one thing, because you were talking about the HER2 low, which we hadn't brought up yet, but you know, HER2 positivity is defined by immunohistochemistry, where you have strong staining 3+, and that is HER2 positive. And you can also look at gene amplification with a test called FISH or ISH for HER2 gene. But there's all sorts of patients who are 2+ called indeterminate, and then you check for the gene amplification to see if it's positive. Most are not. And then 1+ or 0, which are negative. And so in the using trastuzumab deruxtecan, there had been data showing that there was really remarkable responses in patients who fit into that 1+, 2+, but not HER2 positive by gene amplification. So there's a large phase 3 randomized trial looking at this group we now call HER2 low, which is a newly defined group. And I will say that we don't know that it doesn't work in HER2 0. So we have no idea whether it's just low or not, but it's a fascinating new area of investigation because it could include such a huge number of patients, as you mentioned, Sunil. So you were asking for a comment, remind me again on the...
If you have a patient with advanced disease or metastatic disease who is not traditionally HER2 positive, would you kind of try to, and has say 2+ or 1+ HER2 positivity, Which way would you like to turn? As a triple negative disease with metastatic disease, or a HER2 low with metastatic disease? And are there benefits or disadvantages of treating the patients accordingly?
I don't think we have data yet because we don't have Destiny 4. I mean, I personally have a patient on that trial who's had a beautiful response, and she was 1+ HER2 positive. She's hormone receptor positive and HER2 1+, and she's had a beautiful response to the compound. But until that reads out, I mean, that's an anecdotal response. I'm 1 out of 2 in the 2 patients that I put on that trial. So outside of the context of a clinical trial, I would probably treat that lady as a triple negative patient.
Also, the number of patients who are triple negative in the HER2 low trial is a smaller percentage because they suspect that the responses are not as good. But I've had the same experience as Chuck with the HER2 low trial when patients with hormone receptor positive disease. So that's been exciting, but I wouldn't use it before we have real definitive data. I'd just like Chuck to ask you how you, and then we'll move off HER2, how you sequence the new therapies in HER2 positive disease. If you have a patient who's gotten treatment, Valerie, you got neoadjuvant chemo, is that what you said? So we can use your example. You got neoadjuvant chemotherapy and you had a pathologic complete response?
I did, yeah.
So in a patient, that's really, it's such a great thing when that happens, and ER negative a little bit more frequent than ER positive. But we saw in the Catherine trial that, you know, TDM1 can improve outcomes. So now you have a patient with metastatic disease who's had already pertuzumab and or Perjeta and Kadcyla. So how do you sequence your treatments now, Chuck?
Well, I have a couple of other comments first. First, with regards to Valerie, I think your long-term prognosis is probably going to be very good because you are hormone receptor negative. And in patients who have very late relapses, it's almost always the hormone receptor positive patients who have late relapses. So it's just like the triple negatives who do so poorly up front are very, it's very rare that they relapse late. So for you personally, I would be very encouraged. The second thing is I'm actually writing a book, and the book is Metastatic Breast Cancer Defying the Odds. So I've got about 40 patients, just 40 from my practice right now. And, you know, with metastatic disease for 10, 12, 15, 22, the longest is 40 years with metastatic breast cancer. And it's not my practice. Hope has these patients. Every medical oncologist has these patients. And it's the heterogeneity of breast cancer. But I think that the reason I'm writing the book is I think that it would be very good for newly diagnosed metastatic breast cancer patients who have just been told that they have incurable, not untreatable, but incurable disease. Okay, now to get to your question, the big issue, and we can throw in another drug as of today. I guess you know, I know Sunil knows, we now have another drug.
Margetuximab.
Margetuximab. And you mentioned ADCC before in the context of tucatinib, and for margetuximab, that's the key to that particular drug. But I wouldn't throw that into the sequence right now because the results to me were underwhelming. But it was approved by the FDA today. So we have another anti-HER2 new drug to deal with. As far as sequencing, I would go back to sort of the beginning. Most everybody would get Cleopatra as first line, and I think second line is sort of up for grabs at the moment. Actually, everybody thinks that it's third line that's up for grabs, but I think that between Her2 Climb and the deruxtecan data, Kadcyla is going to come into question as the ruling second line drug. And if I had a patient who had brain metastases after Cleopatra, I would have no hesitation at all to move them to Her2 Climb before I would move to Kadcyla. So that is a sequencing question. As far as deruxtecan, I think that I would still probably leave that because of its toxicity, and probably move to the tucatinib first, certainly in a brain metastasis patient.
I think that that's really important, and that's really, I mean, we've all been talking about sequencing a lot. I think that's mostly what people are doing, basing on the brain metastases and what we give next, as well as patients who have underlying lung disease or a history of inflammation of their lungs from other drugs. And just to briefly explain, margetuximab is a FC, and this gets really above everyone's pay grade, mine too, but it's an FC engineered antibody that has been altered to, this phone just rings on its own in the clinic. It's been altered to actually increase its affinity, and it may have more efficacy in patients who have are born, you know, just with these different FC gamma receptors that Herceptin binds to, that may have just low affinity binding. So margetuximab is approved based on meeting its endpoint, and there are more studies going on, but I would use it in sequence. You know, my approach in somebody who, for example, developed recurrent disease after having had pertuzumab and having TDM1 or Kadcyla is, you know, I would either use the Her2 Climb regimen, depending on brain mets, tolerability, and then trastuzumab, deruxtecan, and HER2, but then I would use margetuximab next. So I think that it will have a role as we have new agents now. It's really interesting. So I wanted to make sure we move on. And so I want to open this for anybody to have further comment about sequencing or thoughts on any of these agents.
You didn't mention neratinib.
That's a good point. And I think neratinib had some interesting data that was presented at San Antonio with patients who did not have a pathologic complete response to neoadjuvant therapy. A lot of people noted that this was a subset of a subset of a subset. You know, people have hormone receptor positive disease, did not have a pathologic complete response, and started neratinib within a year of completing trastuzumab. So that in those patients, the difference in disease-free survival was dramatic. I mean, really huge. And so I don't know, how do you use that? To anybody want to pop in and note, how do you use the neratinib now that we can control diarrhea better?
I think you're talking about the extended subset of patients who are treated, and those patients who have ER positive, HER2 positive disease after they completed neoadjuvant therapy, in comparison to those who are not ER positive, had a longer invasive disease-free survival with an absolute value at 5 years, I think of 5.1, and the distant disease-free survival of 4.7, in comparison to the old patient population, where it was really 2.5% and 1.7 at 5 years. But I have to say also the overall final analysis of extenet at 8 years, overall survival data comparing neratinib to placebo, there was really no difference. It was like 90.1% in the neratinib group and 90.2%. So I think in a subset of patients, of those that are hormone receptor positive, who initiate neratinib within 1 year, like you said earlier, of completing trastuzumab, there seems to be a benefit in invasive disease-free survival as well as distant disease-free survival at 5 years.
Yeah, I think the data that they presented, that Frankie Holmes actually presented, also looked at this group who did not have a PCR, again, fitting the same criteria you mentioned, and then there was a difference of 9.1%. But I think it's hard when you have subsets of subsets. And I guess the question is there a patient for whom you would recommend extended adjuvant therapy with neratinib? Valerie, did you say you had received neratinib based on the extended data?
I did mostly, it was newly approved shortly after I finished Herceptin. And I was in that phase of treatment of really wanting to know what was next and how can I keep this from, coming back. And being HER2 only, it was the answer I got was exercise, eat healthy, maintain a good weight, avoid alcohol, don't smoke, which are things I was doing when I got cancer. So I was really like searching at that stage. I had a little bit of energy back having gone through the treatment and said, I got to figure this out. I want to know what's going on. And so it was July of that year. I finished in May. July is when it got approved. So I went to the doctor and I said, hey, I'd like to give this a shot because I don't have anything else to protect me. And the first oncologist I had worked with was like, I don't think so. The diarrhea is really bad. And I said, look, I've done diarrhea. I've been on Herceptin and Perjeta. I'm okay. I'd rather try it. Ended up getting a second opinion, and the second doctor said, let's try it. Let's go with it. I was her first patient on it. I successfully completed the year with the full dose. I was very motivated. The first 2 months were the worst as far as the diarrhea goes, but it was manageable. I lived my life. I did not miss a day of work. I did have a few nights where I slept on the bathroom floor for a little while, but I wanted the extra protection. The data doesn't really support, having the PCR and then having HER2 only, but I feel better protected. At least I know down the road, if this does come back for me, I know I did everything I could.
I think that's really important. And I think it really emphasizes the point that the patients do, every patient needs to be a partner in their care and help make those decisions. We've really improved the diarrhea from neratinib tremendously. And I know you were aware of that from the control trial where you now start low and go up each week. And you can get up to the full dose by week 3. I usually wait till 4 weeks in that situation, but I would still use, a lot of questions have come up about now that we have TDM1, would you still give neratinib? And I think that the patient population are patients who have residual disease, have higher risk disease, multiple positive nodes who've gone to surgery, et cetera. I think that maybe what we could do, unless there's a burning comment, is go on to talk a little bit more about I'm just going to briefly mention a question. Somebody asked about a low-dose prednisone regimen with trastuzumab deruxtecan to prevent ILD, but there's no data on that, so I wouldn't give continuous low-dose prednisone during the TDXD or and HER2, and I can see Chuck also agrees with that. But so we're going to move on and talk about some of the genomic data that was presented at San Antonio and where we sit with that. There was actually a whole bunch of interesting presentations. We saw data from Biotheranostics looking at some of the information about who might benefit from longer duration endocrine therapy, which is a big question because, you're really continuing therapy that reminds people that they had cancer and gives ongoing side effects. So, it's continuing endocrine therapy after 5 years is the really big question. They looked at TransATAC, and then there's been some other data looking at aromatase inhibitors as well. So I can open that up to whoever might want to comment. Sunil, maybe you could just briefly comment about the natural history of this cancer and why that extended adjuvant endocrine therapy is so important.
Sure. So basically the issue is with ER positive disease, unlike triple negative as we heard before, ER positive disease can recur 5, 10, 15, 20 years since the original diagnosis. And that's really been something that worries the oncologists and patient community a lot. The incidence of late recurrence is thought to be approximately 1% per year or something in that nature. And that's the main concern, that the patients have already gone through chemotherapy, and then how long should they be going through anti-endocrine therapy or hormone therapy? And that's where BCI has found itself a nice home. It's been really the major assay in that particular era or that particular zone to figure out which patients are at greater risk of recurrence later on in life as opposed to those who are not as such an increased risk. And so In this particular study, they basically started to look at a variety of drugs. I mean, the original data was from MA17 that was used for the development of the assay. It originally started as the MGH2 gene signature, but has been now increased number of genes. And it is really a fairly robust signature for identifications of patients who are likely to recur. Or recur following endocrine therapy. So the questions that they are now trying to ask is, are there subsets of patients that you can identify who might benefit from longer duration of hormonal or endocrine therapy? So again, there are data to suggest 5 years is good, 10 years might be better. And then again, you know, it's a constant reminder for the patients that they have had breast cancer and they're taking drugs for really nothing that they can feel for. And they have been disease-free for a long time and compliance becomes an issue. So having gene signatures or tests that will say that, okay, you are at higher risk, you better continue, is a great motivation factor. And they are now presenting data from multiple clinical trials that basically show more or less the same thing, that this particular assay has a role to play in determining which patients are at greater risk. And they have now something like the 4th trial that they have looked at to show that the assay is a good predictor of who should get extended hormonal therapy or extended aromatase therapy. So that's really the spectrum of disease that we are talking about. And we're talking about recurrences that occur beyond the 8, 9, 10 years of original diagnosis.
Can you just say something briefly about the test?
So the test basically started off as a 2 gene signature, IL-13B, and forgetting the second one is a HOX.
HOXB11.
Maybe.
Yeah, so it's one of the HOX genes, and basically the ratio of those 2 genes was important. And then since that time, they've added a couple of additional genes. So it's now 7 genes, if I'm not mistaken, that are used for this particular assay. It's very similar to the Oncotype assay in terms of its design, and that it uses RT-PCR for the analysis and gives out a readout as a score, and the score is used to decide which patient is at greater risk of recurrence.
So just clarify that a little teeny bit, and it's the breast cancer index comes in 2 different kinds of tests, the predictive and prognostic, and the predictive test is called an HI biomarker. And actually, you know, that's what's the problem is we don't use these biomarkers for anything else. So it's a very clever approach. HOXB13 over IL-17BR. So there you go. And that they have suggested might predict benefit from extended endocrine therapy and predict potentially outcome as well. But the prognostic is, you know, what is the individual patient risk of having a later distant recurrence? And that's where the algorithmic combination of 11 genes comes in. So you get the HOXB13 and IL-17BR, but then you add in 5 more genes, and altogether it's 11 genes that you're looking at. So it's a complicated assay to think about, a little bit different from what we're used to thinking about in the first, you know, deciding about chemo or not. But it's actually quite fascinating. And a number of trials now, they've gone retrospectively. So looking at trials already done where patients got either, you know, an aromatase inhibitor after tamoxifen or after an aromatase inhibitor to extend after 5 years, to try and understand, you know, if patients were randomized to either placebo or aromatase inhibitor, tamoxifen or not, or shorter versus longer aromatase inhibitor, could they predict who would benefit from the longer exposure to endocrine therapy? And they've already shown that it's prognostic, certainly. So I don't know, Chuck, do you use this at all, this test?
I started using it originally when it came out with MA17, and then I got disenchanted with it because I felt that we only had really one data set that we were working with, but now we have 4 separate data sets, and all of them have been quite consistent. In fact, you know, in terms of the number, the percent benefit is around 65% in each of the 4 trials. So I've started using it again. You know, it's a difficult issue because each of these trials shows a benefit of what, 4 to 5%, and of the 4 to 5%, maybe half of those are local recurrences that are curable by surgery. So you're talking about 95% of patients being treated with 10 years of hormonal therapy when they might not need it. So if indeed, as now shown in 4 separate trials, consistent results, I think there certainly are patients who would love to come off their anti-hormonal therapy. And this is another piece of information that could be valuable in making that decision, helping them to make that decision.
Yeah, it's a very well said. And I've actually had pretty much the same course. You know, that initial small analysis was exciting and then nothing for a while. And now we have all these data sets which are showing the same thing. And one of the questions came up about whether you can use BCI in patients who started on an AI for 5 years and are trying to decide on longer therapy, or was it just limited to tamoxifen patients? You know, we have, of course, Trans-Atom that looked at 10 years of tamoxifen versus 5. We have patients who took a TAM and went on to an AI, and we have patients now at the IDEAL trial who took an AI and went on to an AI. So I think we have all those groups represented. Right? Comment?
You know, I think, I mean, the main comment that I have here, and since we're talking about the, you know, HER2 positive breast cancer, is the subset of patients who were ER positive and HER2 positive that were included in the validation of the BCI. And, you know, I think the, you know, the HER2 status did not affect the validation of the BCI. And there was actually a study that was presented in ASCO this year, this past year as an abstract, where they looked at the interaction between extending endocrine therapy, the BCI HI score, as well as the HER2 status. And they looked at the interaction between the 3 different, and there was really no interaction, in other words. And although the data is small, looking at, you know, this group of patients who are ER and HER2 positive, it seems that, you know, the results of the BCI are still informative. And again, it has to be taken into the, you know, the context of the whole clinical picture in terms of, you know, as you know, the patients, how are they doing on treatment, what they want, you know, to extend therapy or not. There's so many different things to take into consideration when it comes to extending endocrine therapy beyond 5 years.
Yeah, so Peggy, any comments about how you would, as a patient, look at a test like this that might give you some insight into benefit? I think one of the things they've done in changing the way they report it, because it used to be you would get the prognostic and predictive, so you would see like, oh, you have worse disease, so your chance of recurrence is greater, but you won't benefit from endocrine therapy. And we all gave the feedback that this was not the kind of thing we wanted to tell our patients. But so they've changed it to sort of wrap it in all together now, so that's better. But what do you think about that?
You know, like we've said before, I think more information is always better. The idea that some women, number one, can now avoid chemotherapy is a wonderful thing that's developed. And then if we extend that down to, you know, post-treatment, adjuvant treatment as far as tamoxifen and AIs, but I'm triple negative, so none of that was available to me. You know, we just didn't even talk about that. But I hear, when I look at numbers, I do know that in one study, it showed that the majority of African-American women tend to take their tamoxifen or their AIs for maybe a year or two, and then they decide that they don't need it, that they need their heart medicine more, or they need their diabetes medicine more. So I think if we can find more information, and one of the studies I looked at really did look at this, about who it really is indicated for, if we can go deeper than just the mammoprint, that we can get more information to give every patient, but especially those patients that we know very often go off of their tamoxifen or their aromatase inhibitors, and we can give them more information, either positive or not. I think that's going to make everybody happier. The patient happier, the doctor's going to be happier. So I loved looking at that, some of the information out of San Antonio about that. Everybody needs more information, and this kind of research is very valuable. Number one, because cost effective. Do you take it and expend the cost or not? And so I think we need to be looking at everything, but I just think that we need to be able to tell them why they need to be taking it for sure.
Yeah, and I think the risk versus benefit is always a huge discussion, and sometimes really hard for us as clinicians to understand how to best communicate the benefit. I think that's really the big question. People are afraid. They know there's a late risk. The risk of recurrence could go out to 20 years, and if you could really reduce that risk, why wouldn't you if you could tolerate the agent? But then you're balancing tolerating something which has an effect on your life every single day. So it's, small percent benefit, et cetera. But I think the data is intriguing. I expect we'll see more because there was the NSABP trial also that looked at 5 versus 10 years of an aromatase inhibitor. And we're hoping to see more data on that as well. So it's been helping. So we also saw, I don't know if there's any other comment. Valerie, you want to comment on anything before we move on to the other genomic tests?
I second Peggy's statement about the data. I know that if I don't have data, my head goes into the worst case scenario. And so when I tell my oncologist what I'm thinking, she'll say, oh, let me run the numbers for you. I know it's not as bad as what you're thinking. So that's very helpful to have the extra data.
We saw also a lot of data at San Antonio this year about gene expression assays in addition to the biotheranostics assay, and how we can determine which patients do or don't need chemotherapy. There was an interesting presentation by Joe Sperano using the recurrence score with a clinical prognostic test that's now online for node-negative disease. But I think where we saw a lot of data was in node-positive disease, the RxPonder trial, and then a really interesting presentation by Laura Vantveur called How Low is Low, and really looking at how to use the mammoprint or 70 gene assay to try and understand who doesn't need chemotherapy. I guess anybody who wants to comment on that, Sunil, maybe you just briefly comment on the differences between the assays.
So, well, let's start in 2002. When we were really
brief.
When we were really thinking about trying to find an assay for genomic predictor, there were two assays that were at the table. One was the oncotype, and the other was the mammoprint. And the major problem with the mammoprint was that it required fresh frozen tissue. And therefore, the TELER-RX trial was based on oncotype. There was really no major difference as to why we selected that, apart from the need for frozen tissue for the mammoprint assay. Now, things have changed quite dramatically, and mammoprint now can be done on paraffin just like any other test. So there's little to kind of compare directly between the two assays, whether you're talking about mammoprint or oncotype. Just like we have the RxPonder assay that shows that low oncotype patients with node-negative disease can be spared from chemotherapy. There's similar data from mammoprint that suggests that, again, good prognosis patients can be spared from chemotherapy. The trouble I have with some of these is the comparisons of clinical risk versus genomic risk, and what is the degree of benefit when the clinical risk is high and the genomic is low, and the genomic is high or clinical is low. And I don't really understand it, because the designs get very complicated. And I don't really understand whether there is any degree of benefit that one can find with either of the assays that we have so far. So there are some limitations there, whether it's Oncotype or with MammaPrint. But the good part basically is that if you are not sure, if you want the confirmation of what's going on, and you think that you are at high risk, or you get everything that is kind of borderline, slightly larger tumor, grade 2, maybe may have a node or may not, a small nodal deposit. These molecular assays are a great way of confirming the clinical impression and give you a quantitative information as to what's going on. So that's the one major advantage of any molecular assay, that it is not as subjective as a clinical examination or pathologist examination of the tumor. Now, as we have heard over the years, we have these subcategories that one can define. Original Oncotype was defined as greater than, low was defined as greater than 18. With TaylorRx, we use a different definition of less than 11 as good prognosis, 11 to 25 as intermediate. So there are these kind of, as we get more and more information, we can kind of change the boundaries of what is good prognosis and what is bad prognosis. So there is a group of patients that we now know can definitely be spared from chemotherapy, whether they are node positive or node negative. And that is important. Again, most of the data is in relatively normal sized tumors. So that is 2, 3, 4 centimeters max, and not on 9 centimeters or largest tumors. We don't have much data on nodes that are more than 4 or those kind of patients, because we still believe that the risk is high enough that we can't really experiment with them to try to figure out whether they may or may not benefit from chemotherapy. So clearly, all of these assays have a role to play. There are individual preferences based on which data you strongly believe in, as to whether you should use the Oncotype or the MammaPrint. Their personal preferences for some people, because they have a pipeline in their office that they have been using one and they continue to use so. There are cases where one assay shows something is high risk and other assay shows that it's a low risk patient, and those discrepancies have not been solved yet. So there's no real advantage of doing multiple assays on the same tumor, because you might get different answers, and resolving those differences has really been difficult, because those subset analysis are never quite powered to figure out whether there is benefit or not benefit. So that's the overall kind of viewpoint of genomic assays in this space. The newer players in this space are the endopredict type assays that also come in. And again, the most data is on using the two main assays, the Oncotype assay and the MammaPrint assay. Now, that
was really helpful. Actually, Sunil, sorry to interrupt. I wanted to get a little bit of a thought about how people interpreted the data from San Antonio and how they're going to be using it. So I hope that's okay. I'm conscious of our 11 minutes left.
So maybe, yeah, Dr. Vogel.
Chuck, go ahead.
Yeah, I think that both Oncotype and MammaPrint now have sort of come together, and both of them, I think, are good assays in being able to help us to decide who should get chemotherapy and who shouldn't get chemotherapy. And I'm more intrigued with the emerging data from MammaPrint, because it goes beyond that one predictive piece of information, chemo or no chemo. And that is that because because MammaPrint also includes something they call Blueprint, which basically is looking at intrinsic subtypes, you get a lot of intriguing information that really isn't quite ready for prime time yet, but it's really quite intriguing. So if you're going to do mammoprint on luminal tissue, because that's what you mostly do it on, you find out that when you do intrinsic subtypes, you can find a lot of other interesting information. First of all, without the intrinsic subtypes, you can take a look at the mammoprint index and looking at the super low, which started with Laura Esserman's original data and now the Vanderveer data, taking a look at how low can you go, and do these patients, how much benefit do they actually even derive from anti-hormonal therapy? I'd be thinking about that. And then looking at the subset of luminal patients who, when you do the intrinsic subtype, turn out to be basal. So are you going to treat this patient with hormones, or are you going to treat this patient as a triple negative type of patient? And that's like in the neoadjuvant setting. And then you have the triple positive patients who, where you have a major breakdown that they can be anything. They could be a HER2 positive intrinsic subset. They could be a luminal A. I have a lady with a clear-cut, strongly FISH positive, classical luminal A tumor.
Yeah, I mean, I think these are really such important points that you're making, you know, how you deal with that information. I do make the point that in general, when I'm talking to patients, that we don't know how to use the luminal subtypes yet in order to determine treatment. And I think it's very hard to withhold HER2, targeted therapy. And, you know, I have had also, you know, the mammoprint score goes like this, and, you know, ultra low is over here, and then ultra high is over here, mammoprint high 2. And I've had a patient who was luminal B and had a score of -1. I mean, as high as you can go. And we would have predicted that was basal, but it's not. And now she had an excellent response to BRCA1 mutation, excellent pathologic CR to neoadjuvant chemo. So, you know, it's a really interesting time. I think one of the questions that has come up by the audience, and I want to cover one other topic, so we'll try and just answer this question and move on, but is how do you deal with all the data? We saw data from the ATTAP trial using Ki-67 assessment. If you drop the speed of growth of the cancer, you could stay on hormone therapy, and if you didn't, you should get chemo. We had data from our exponder suggesting only premenopausal women benefit from chemotherapy with node-positive disease. Even in ADAPT, it seemed like patients who had 3 or more nodes might need chemo. They didn't do as well. So if you had a patient in clinic now, we'll make it very simple, you know, 2 cases, postmenopausal, so a 60-year-old woman and then a 40-year-old woman, and they have a mammoprint that is low risk and 1 positive node. Do you feel comfortable foregoing chemotherapy in that patient? If they have a recurrence score of 12, what are you going to do with those patients? 1 positive node. So, Wade, do you want to first comment?
So say that again. Actually, what I'm gonna say, there is a paper that we published earlier this year with Sunil and our group looking at clinical examples where you really have to make these decisions in terms of, the positive node in a premenopausal woman and a postmenopausal woman. So I don't have that paper in front of me, but I would like to refer, and I'm happy to share it. I'd like to refer the audience to that paper.
Well, I think that that's a good suggestion, and certainly I don't think we have time really to talk about it in detail, but my take on all of this is that if I have a postmenopausal woman with either a low-risk mammoprint or low recurrence score and who has 1 or 2 positive axillary nodes, the data so far suggests that there's no benefit from adding chemotherapy. And I feel really comfortable using endocrine therapy alone. Whether or not we're going to add any other targeted agents is a big question long term. Those patients I probably would treat for longer. If I have a premenopausal patient who has one positive node and either a very low mammoprint or very low recurrence score, I feel comfortable with endocrine therapy, but I always use ovarian suppression. If I have a patient who has a higher recurrence score, or really, they didn't show any continuous scale differences with recurrence score and benefit from chemo with our exponder. But I think that if you had 3 positive nodes, for example, I'm starting to get into an uncomfortable area where I'm going to give chemotherapy to a premenopausal woman. I do talk to women about how the benefit is narrow, but we just don't know enough yet. And again, I'm a big proponent on ovarian suppression because I think that's an important part of this. The Ki-67 response to neoadjuvant therapy is really intriguing. You could give 3 weeks of hormone therapy and see that your cancer really slowed down its turnover or proliferation with that Ki-67 marker. If that would be a way in postmenopausal women to be able to determine who needed chemo or not, who has more cancer, that's fabulous. And the ADAPT trial is really encouraging about that. Chuck, do you generally agree with that approach?
Well, I do, but we're limited. Our institution doesn't routinely do Ki-67, and Ki-67 is notorious. Well, this is in Sunil's ballpark, but Ki-67, the cut points are all over the map in published papers, and the quality control for Ki-67 has been poor. And so in these studies that are done using central Ki-67, I would believe them, and I believe the data, but I don't think that it's ready for prime time because I don't think our pathologists have got their stuff together.
Yeah, I think, it's interesting in the Monarch E trial, we saw that there was a lot of, central confirmation differences. Sunil, one sentence?
Yeah, quick comment. So a lot of work has been done since Mitch Dowsett and people talked about the JNCI paper about the Ki-67 heterogeneity. A lot of work has been done and the number of standardized guidelines have been put.
We have like 2 minutes. I gotta have you.
I'll just one more sentence.
Yeah.
And a part of the thing is post monarchy, there's going to be a lot more standardization of Ki-67 in terms of analysis and assessment. So
yeah, I think, it's really, there's been, as you pointed out, there's certainly a way to standardize it with testing. But the last question I wanted to ask everybody, which I think comes out from the Ki-67, we saw some early exciting preliminary data from the Monarch E trial with abemaciclib as a CDK4/6 inhibitor, but palbociclib trials, 2 of them did not show benefit, and there's all sorts of different reasons we can't get into. But does that data alter how you use CDK4/6 inhibitors in the metastatic setting now? Chuck, does it change anything about how you use CDK4/6 inhibitors?
For me, no.
Wade, would you take that as a difference?
No, it doesn't change how we use CDK4/6 inhibitors.
Yeah, it hasn't changed to mine either. And then I just wanted to, we have 1 minute left. So I wanted to ask Peggy and Valerie for any last comments about the things we've talked about and guidance for us.
So I'll go first real quickly. Because I'm a policy wonk, next year is going to be a strange year with our Congress. And I am concerned about cancer funding. And so I want everybody to remember that you have a voice and we need to keep the pressure on that cancer is still very, very important. And we need all the research dollars possible.
Wonderful. I agree. Valerie.
Yeah, I think I would just like to close thanking you guys for allowing me to have a voice on the panel. And also, especially this year, it was really highlighted, but all the years that I've been going through cancer treatment, my doctors are my heroes. And I just want to thank each and every one of you for the hard work that you do and the commitment that you have to saving our lives. It just means the world. You guys are my heroes. So
What
thank
a
you.
wonderful way to close our session, Valerie. I want to thank everybody, Sunil, Muaiad, which I think I'm getting right, Valerie, Chuck, and Peggy. I usually have to practice a little first, you know, and for all of your contributions. This was just an amazing panel. I want to also thank Total Health Conferencing for making this possible and for their interest in making education available virtually this year. And then also our sponsors, Pfizer, Agendia Biotheranostics, and Daiichi. Great discussion, exciting way to end the year for us with a lot of new data. And I wish you all a great new year and holidays, depending on what you're celebrating. So thanks very much.
Thank you.